So coming to TMD disorders with arthrogenous origin, disc displacement with reduction, clicking sounds, normal mouth opening, disc displacement without reduction, limited mouth opening due to permanently displaced disc, and TMJ hypermobility and subluxation, joint laxity causing jaw locking in an open position. Coming to the third and the last criteria of TMD diseases, degenerative and inflammatory disorders. Osteoarthritis, progressive degeneration of the TMJ cartilage leading to crepitus, pain and dysfunction. Rheumatoid arthritis, it is an autoimmune mediated inflammation causing joint destruction. Coming to the epidemiology and prevalence of the TMD diseases, it affects the 5 to 12% of the population with a higher prevalence in women with a ratio of 2:1 due to the estrogenic influences and the hormonal imbalances. Peak incidence is between the age groups of 20 to 40 years. Etiology and risk factors, it is multifactorial with factors contributing including occlusal factors, malocclusion, premature occlusal contacts, excessive overjet or crossbite, bruxism and parafunctional habits, nocturnal teeth grinding, diurnal clenching, and psychological factors, stress, anxiety, depression affecting jaw muscle activity, trauma, direct injury, macro trauma or repetitive micro trauma, that is a chewing habits, postural and functional factors, cervical dysfunction, head and neck, postural changes. Coming to the pathophysiology of TMD pain, role of the masticatory muscles. The masticatory muscles such as masseter, temporalis, medial and the lateral pterygoids are the primary muscles affected in the myofascial TMD. Muscle overuse form the trigger point formation, which is referred to the head, neck, ears and eyes. TMJ dysfunction and disc pathology. Normal function, the disc moves smoothly between the condyle and the articular eminence. Disc displacement leads to clicking, pain and joint locking, and osteoarthritis and bone remodeling leads to flattening of the condyle, joint pain and crepitus. Neurophysiology of the TMD pain. Chronic pain mechanisms involve nociceptor sensitization, central pain processing pathways and cortical plasticity. Central sensitization changes in brain stem pathways, that is a trigeminal nucleus claudalis. And occlusal and TMD, a controversial relationship in which the occlusal discrepancies were thought to cause TMD. Current research suggests that TMD is multifactorial with occlusal being a secondary factor. American Association of Dental Research suggests no strong evidence links with occlusion as a primary cause of TMD. So coming to the TMD occlusal appliances. So occlusal appliances in the TMD management include first the definition. These are removable intraoral devices designed to modify occlusal relationships, reduce muscle tension and protect the TMJ. Goals of occlusal splints include reduce the parafunctional activity, whether it is branching or clenching, stabilize occlusion and minimize joint overload, relieve muscle hyperactivity and myofascial pain, and lastly the reposition of the TMJ to improve the condyle disc coordination. Classification of occlusal appliances. First is stabilization splints, in which come Michigan and the Tanner splints. These are hard acrylic full coverage appliances used in myofascial pain and bruxism. Maintains centric occlusion, reduces muscle hyperactivity. Anterior repositioning splints are the second category of the occlusal splints taken into TMD disorders. These are indicated for disc displacement with reduction, that is with the clicking sounds. Repositions the mandible forward to improve the disc condyle alignment. Soft splints is the third category, made of resin, acrylic or silicone. It provides short-term relief but may encourage bruxism in some patients. And the last category is hydrostatic and pivot splints, alters occlusal forces and joint loading, used in patients with joint overload or degenerative TMD disorders. Coming to the future limitations and controversies. Regarding occlusal splint research, placebo effect in splint therapy, studies show some pain relief even with non-functional splints, suggesting a psychological component in the treatment. A patient belief in therapy contributes to the healthy outcomes of using occlusions in TMD disorders. Lack of standardized protocols, studies vary in splint design, material, duration of use, making comparison difficult. Need for standardized guidelines for future research is the mandatory concern as of now. Long-term use and occlusal changes, excessive splint use for more than 1 year can cause bite alterations and can cause posterior open bite, anterior intrusion, and regular monitoring is essential. So what is the future directions of use of occlusal splint therapy in dentistry? Digital dentistry and CAD/CAM designed splints can be incorporated into the treatment plan. 3D printed occlusal splints offer high precision for better patient adaptation. Artificial intelligence AI in TMD diagnosis, AI based CBCT and EMG analysis are used nowadays for optimal splint designs. Personalized medicine in TMD management. Future research focuses on individualized splint therapy based on genetics, neuromuscular profile, and psychological factors. Coming to the conclusion, occlusal splints provide significant relief in TMD management, particularly in muscle pain and bruxism cases. Effectiveness varies on splint type, patient compliance, and underlying pathology. Best results are seen when occlusal appliances are a part of the multimodal approach. More high quality research is needed for the treatment protocols and improve the long term success.